Hey y'all, it's Dr. Atkinson. Let's talk sodium, the quiet little electrolyte that can make you feel like $1,000,000 or land you flat in a hospital bed, wondering why your brain feels like a scrambled egg. We're going to cover both ends of the spectrum: hyponatremia, too little sodium, and hypernatremia, too much sodium. And you'll see why I call this chapter salty business. First things first, what even is dysnatremia? Dysnatremia just means your sodium level is off. Normal sodium lives between 135 and 145 milliequivalents per liter. Below 135, that's hyponatremia. Above 145, that's hypernatremia. And here's the kicker. It's not always about how much sodium you've got. It's about how much water is hanging around with it. Think of sodium like the friend in the group who's great at balance, until the wrong crowd, water, comes in and throws the whole vibe off. Part 1, hyponatremia. When you're too fresh, not salty enough. Hyponatremia happens when sodium drops under 135. Sometimes it's because you've lost sodium, vomiting, diarrhea, nasogastric suction, heavy sweating. Sometimes it's because you've diluted your sodium by taking in too much water, like chugging hypotonic fluids, having SIH, or overdoing the hydration thing on a marathon. What's happening inside? Water moves into your cells, making them swell. In your brain, that swelling is bad news. There's no room for expansion in that skull. Symptoms: headache, confusion, seizures, coma if it's severe and fast. You might see cramps, weakness, and gastrointestinal upset too. In older adults, the mental status changes can be brushed off as just getting older. But if grandma is suddenly acting confused, check that sodium. Diagnosis: serum sodium less than 135 milliequivalents per liter. Serum osmolality less than 275 milliosmoles per kilogram. Urine studies help figure out if it's a kidney thing or not. Treatment: mild, cut back fluids, give a little extra salt. Severe neurosymptoms: cautious hypertonic saline, 3%. SIADH, fluid restriction, and sometimes loop diuretics. Athletes: replace sodium during long, sweaty events. Nursing role: monitor neurostatus like a hawk. Watch labs. Keep seizure precautions ready. Daily weights, intake, and output tracking. Teach about sodium in the diet if appropriate. Part 2, hypernatremia. Too salty for your own good. Hypernatremia is when sodium climbs above 145. It's usually not because someone's been licking salt blocks. It's almost always water loss that's outpaced sodium loss. The body's first line of defense? Thirst. If you're healthy and awake, you'll drink and fix it. Hypernatremia pops up when you can't get to water. Think older adults with impaired thirst, babies, unconscious patients, or anyone physically unable to drink. Causes: water deprivation. Hypertonic tube feedings without enough water. Watery diarrhea. Diabetes insipidus. No ADH, water just pours out. Excessive sweating and heat. Certain meds or over-the-counter products with high sodium. Hello, Alka-Seltzer. What's happening inside? Water shifts out of cells into the bloodstream to balance that high sodium. Your cells dry out. Brain cells don't like being prunes. Symptoms: thirst, unless your thirst mechanism's broken. Restlessness, disorientation, lethargy. Mild temperature increase that goes away when you fix the sodium. Diagnosis: serum sodium greater than 145 milliequivalents per liter. Serum osmolality greater than 300 milliosmoles per kilogram. Urine osmolality high, unless diabetes insipidus, where it's less than 250, basically water. Treatment: replace water slowly. Too fast and you risk brain swelling, cerebral edema. Hypotonic solution, 0.45% sodium chloride, is the go-to. Dextrose 5% in water can be used, but watch for osmotic shifts. Correction rate less than or equal to 0.5 to 1 milliequivalent per liter per hour. If diabetes insipidus is the culprit, give desmopressin acetate, synthetic ADH, nursing role. Offer fluids regularly if the patient can drink. Add water flushes to enteral feeds. Watch sodium content in meds and diet. Monitor neurostatus closely during correction. Watch for signs of cerebral edema if sodium comes down too quickly. Special note on athletes and extreme exertion. Athletes can run into trouble on both ends. Sweat out sodium faster than water, hyponatremia. Lose more water than sodium, hypernatremia. Both can cause confusion, seizures, or worse. This is why sports drinks aren't just expensive Kool-Aid. Sometimes they're literally keeping your electrolytes balanced. Bottom line, sodium isn't just table salt. It's a key player in fluid balance, nerve transmission, and muscle function. Your job as a nurse is to know the numbers, spot the symptoms early, and manage the fix without swinging the patient into the opposite problem. If sodium changes are fast, the brain feels it first. And whether it's too little or too much, the correction has to be thoughtful, measured, and backed up by frequent neurochecks and labs. So next time you're looking at a patient's sodium level, remember, in the salty business, slow and steady wins the race.